Okay, so Chapter 6, Maternal Adaptation During Pregnancy. So this is talking about how the mother takes on pregnancy, all the things that happen, the changes that happen in her body. So first off, there's signs of pregnancies, and presumptive signs are those possible signs, things which happen during pregnancy, but they also happen during everyday life too, so it's not something that you can completely stand on and say, I'm pregnant. They're presumptive signs, they're possible signs. So symptoms that women experience, reports to the healthcare provider, subjective signs. Again, subjective is something that the patient says happened. Objective, we observe it, we see it. So taken alone, each sign can have other causes besides just pregnancy. Probable signs are those detected by a trained examiner. So these are our objective signs. These are things we see with our own eyes. And then positive signs are diagnostic signs. There is a test that says, yes, you are pregnant, and gives us an absolute positive sign, like actually seeing the fetus. So possible signs of pregnancy and other potential causes. 3 to 4 weeks plus, you can have early breast changes. However, you can also have early breast changes because of oral contraceptives. So that's not exactly a positive sign. 4 weeks plus, you can have amenorrhea or a missed period. However, hormonal imbalance, emotional stress, or illness, or working out, you know what I'm talking about. Working out too much can also cause you to have a missed period or not bleed that month, so not exactly a positive sign. 4 to 14 weeks, you can have morning sickness, but you can also have gastrointestinal disorders, pyrexia illnesses, you're just not feeling well, you caught the bug, so not always a positive sign. Probable signs of pregnancy and other potential causes. 6 to 12 weeks, bladder irritability can also be associated with a UTI or a pelvic tumor. 4 to 12 weeks, presence of HCG in the blood. Now, HCG is what we usually, if you pee on a stick to find out if you're pregnant, it's the presence of HCG. That's a hormone in the urine that picks up on a positive pregnancy test. However, you could have a hydatidiform mold, and we'll study that more, but that it's a fertilized egg, but it doesn't actually have a nucleus. So yes, it seems like you are pregnant, but that egg would not be viable. It does not have a nucleus, it wouldn't be able to survive. 6 to 12 weeks, again, presence of HCG in the urine, but it could be due to a different kind of tumor, a malignant trophoblastic cancer that occurs in the placenta. 8 weeks plus, uterine growth, and that could be due to tumors. And then probable signs of pregnancy and other potential causes. 16 weeks, Braxton Hicks, it's those painful contractions. However, it could be due to an upset stomach. You could just be cramping. 6 to 28 weeks, allotment of the fetus, it's kind of that bouncing. However, that could be elicited by a tumor, so it's still not a positive. Probable signs of pregnancy or objective signs, these are signs that the doctor will see whenever he does a vaginal exam. And the first one is the Chadwick sign, and that is a bluish purple color of the cervix. So when he does his vaginal exam, he is looking up at her cervix and seeing that there is a bluish purple tone of the cervix, vaginal, and the perineum. Okay? Hager's sign is a softening of that uterine isthmus right by the cervical os. And then Goodell's sign is a softening of the cervix. So again, those are all signs that the doctor would see while he's doing a vaginal exam. Positive signs, how do we know she is pregnant? Positive signs, at 6 weeks, we can see a visualization of a fetus by an ultrasound. So if the woman has an ultrasound and you are able to visually see that fetus, then yes, that is a positive sign, and we know she really is pregnant. 20 to 24 weeks, you'll start hearing the fetal heart sounds by a fetal stethoscope. 22 weeks plus, you'll start feeling the movements of the fetus, palpable by a trained practitioner. And the mother can also feel that. However, that could still, if the mother is the only one who's feeling it, it could be an upset stomach or, gassy burrito, bean burrito, something like that. So it would be fetal movements palpable by a trained practitioner. And then late pregnancy are fetal movements that are actually visible. If you've ever been pregnant, your spouse has been pregnant, it starts to get to the point where her belly will look like a bowl of jelly because that baby will be moving inside it so much. So those are all positive signs of pregnancy. Okay, so let's talk about psychological adaptation to pregnancy. Reproductive changes in the uterus. A woman's body goes through so many changes whenever she's pregnant, and most of them are positive and happy and really neat to experience, but there are some that just are not pleasant in the least. So, reproductive changes in the uterus, change in weight and capacity, change from almost a solid structure to this thin muscular sac. Remember, we refer to it as a hot air balloon. It starts growing. It changes from a pear shape to more of a globular shape. And the location from the pelvis more into your abdomen cavity. 20% of your cardiac output supplies the uterus and the pelvic cavity alone. The cervix and the ovaries, of course, they're going to change too. Vascularity increases, glandular tissue multiplies during pregnancy, thick mucosis plug develops in the opening of the cervix. So you've heard before, after when a woman goes into labor, oh, I lost my mucus plug, and you're thinking, oh my gosh, I don't want to know anything else. Like, you have told me way too much. Well, what she's talking about is the mucus plug is that which goes right up into the cervix, between the uterus and the vagina. It forms so that nothing can get to the baby. Although the baby's surrounded by a sac, there's still that plug to protect them from any kind of infection. Ovulation stops, the corpus luteum continues to function and produce progesterone for approximately 6 to 7 weeks. Alright. Physiological adaptation to pregnancy, still going on. Okay, the vagina and the perineum. Vagina and perineum are affected by hormonal changes and increased blood supply to the area. Again, it's that Chadwick sign, a bluish purple hue. We're not going to be able to see that. Only the doctor or practitioner who is looking into the woman through a speculum and doing a vaginal check will see that. However, breast, you'll be able to note, or she'll tell you about the tenderness, and that usually occurs during the first few weeks of pregnancy. Nodularity of breast tissue, it becomes more dense. Prominent areola with deepened pigmentation, prominent projections of the Montgomery's tubulars, and that's just sebaceous glands on the areolas. They can secrete some oils. Endocrine changes, you're going to see that the pituitary enlarges. Okay, no, you won't see that, but it does. Pituitary enlarges, prolactin levels increase progressively, increased protein binding, thyroid gland increases inside, and of course the need for insulin increases. Not only are you have your need for insulin, but now you are also fueling that baby's need for insulin as well. Hematological changes. You have blood volume, which increases by about 40 to 50%. Increases a lot. Not only is the blood going for you, but it's also now going to baby. You'll have red blood cell volume, which will increase up to 30%. Plasma volume increases by 50%. Hemoglobin changes. It increases 11 to 12, or drops down a little bit to 11 to 12, and then your hematocrit also decreases. Your white blood cell count will increase up to about 1,600, and after labor it will also go up. So whenever you're looking at the charts after a woman has had labor and you see kind of an elevated white blood cell count of like 25,000 or so, do not be alarmed. That is just from labor. It's from the stress of pregnancy and everything. One thing we need to talk about or think about is, along with these changes, like hematological changes, what are we going to be increasing with the woman? What are we going to be encouraging her to take in? And what does she need to think about as far as nutritional goes? That would be iron. She would either need to make sure her food has plenty of iron intake or take some kind of supplement on that. So we'll be watching that as well, and the doctor will be doing lab for that as well. Okay. Cardiovascular changes. Blood pressure is going to actually decrease slightly, and this is something that we are watching very carefully. Anytime that there is an increase in blood pressure, we're automatically going to be suspicious of preeclampsia or eclampsia, and we're going to go into great detail on that in the next few chapters. But we're also going to be watching her heart. It will increase by about 10 to 15 beats per minute, and it's just trying to get that blood to everywhere it needs to go. Cardiac output will increase up to about 40 to 50% by the 5th week of gestation. And then we also have to teach her about supine hypotensive syndrome. And so what you're thinking with this one is, think about a woman just sitting back, and she has a large stomach in front of her. You know, she's carrying this baby, but she lays flat on her back. Whenever you think of that, you need to be thinking about her aorta and her vena cava, and all of that weight from the baby and the extra water, the amniotic fluid, is all of a sudden pushing against that aorta and that vena cava, and it's causing her to become dizzy and short of breath. And so we have to teach her that she needs to be laying on her side. We need to teach her positioning, and you'll see positioning in pages 122 in your book. But she needs to be side laying so that she isn't suppressing the aorta, the vena cava, and because of that, decreasing blood flow to that baby. Respiratory changes, you will see some changes as well. Unchanged or increased 2 to 3 breaths per minute, the rate will kind of increase or go up. Nasal mucosis edematous due to vasocongestion. So she might complain that it just always feels like she's stuffy, she has a runny nose, something like that. Yes, that is normal. And you'll even need to teach her that the nasal lining can be fragile during this time, and so it's not uncommon for pregnant women to get nosebleeds. Tidal volume is increased to about 700 mils. Of course, you got more weight, so you got to get that air deep into those lungs, breathing it in and out. Oxygen consumption increases, and the average particles of CO2 is about 32. Muscular skeleton, you have lordosis increases, and what that's talking about is like a swayed back. All of a sudden you're carrying all this weight in front, and so your back kind of starts doing a curve like that. The next one is talking about your abdomen, and sometimes because of the extra weight, the abdomen will kind of separate from the wall, and the muscle that supports that abdomen will tend to separate from each other. GI changes, intestines are displaced to the sides and upwards and all around wherever they can go, because here's this baby and it's taking over. Because of that, you have pressure changes in the stomach and the esophagus, which of course leads to heartburn and constipation. We must encourage her to drink lots and lots of water, exercise, get out, walk, do those things that will help decrease constipation. Okay. Integumentary. Okay. Chlossma is a mask of pregnancy, and what it looks like are brown spots, often on the forehead, the cheeks, the nose, and it really looks like sunspots. It's just it's called the mask of pregnancy. Linea nigra is that you'll see this darkened line develop on the abdomen, often from the belly button down. And then stria is stretch marks, and I'm sure we all know what those look like. Unfortunately, there's really nothing you can do about stretch marks. It's kind of a genetic thing. Lotion does help a little bit, but honestly, if you're going to get stretch marks, you're probably going to get stretch marks, and they don't really ever go away. But it's usually the abdomen is responding to elevated glucocorticoid corticoid levels and just that stretching of the skin. So here's the pregnancy mass, the Klossner, and then linea nigra, you can just see that darkened line all the way across her abdomen, and then stria, the stretch marks. Okay, so psychological adaptation to pregnancy. A little bit of ambivalence is normal at first. It's just trying to get used to the pregnancy. A little bit of uncertainty in that first trimester. So with the first trimester, our task is to accept the pregnancy, whether it was something you had not really planned for, or you're not married, whatever it is. Somehow you have to come to acceptance of the pregnancy. In the second trimester, our task is to accept this baby, to start planning for this baby, to get excited about this baby. And whether it's you're going to put the baby up for adoption, or no, you're going to keep the baby and it's going to be great and we're going to do everything, whatever it is, you have to accept the baby and start planning for the baby. And then the third trimester is the task of preparing for parenthood. And that can be anything from, oh my goodness, this baby's coming, we've got to go get diapers and wet wipes and what all does a baby need, to we've got to start planning for college and car funds and all this stuff, whatever it is and however that parent prepares for the parenthood. Okay, so changing nutritional requirements during pregnancy. Obviously, the nutritional requirements do increase a little bit with the baby. However, the saying, you're eating for 1, you're eating for 2, you're eating for 3, does not really apply. A lot of times we use that as an excuse to eat anything and everything that we want while we're pregnant. But the truth is that's too much, and there are certain guidelines for how much you should eat while you're pregnant. Okay, so the fetus needs nutrients and energy to build and grow new tissue. The woman is also going to need increased nutrients to build her blood volume and maternal stores. Increased demand for energy and for almost every nutrient type. You have to have a well-balanced diet, well-balanced nutrition. Most nutrient requirements can be met through just careful attention to diet. And then there are several nutrients that require supplement during pregnancy, and that's why we encourage everyone to take a prenatal vitamin. So changing your energy requirements and your weight gain. Energy is supplied mainly from carbohydrates, and you should remember some of this from nutrition. There's increased caloric intake of about 300 kilocalories a day. So that's really the recommendations. It's not a whole second helping, second meal. It's 300 calories a day. And if you'll just start looking on food labels, you'll see that that's really not that much. 300 calories is less than a Snickers bar. So really not quite the eating for 2 like we have in our mind. Okay. Recommended weight gain for the first trimester, we recommend 3 to 4 pounds total, and that's the first trimester. For the remainder of the period of the pregnancy, they say 1 pound per week for a total weight gain of about 25 to 35 pounds. And this is for a woman who has a normal BMI, who isn't overweight, just has a normal BMI. Anything under 17 pounds, they have a fear that that will cause a low birth weight baby. And so with that, it can have many causes, can cause many problems, can cause them to be premature. So we definitely want them over 17 pounds of weight gain. While you're pregnant, of course, you need your proteins, and that helps with growth and repair of those fetal tissues, the placenta, uterus, breast, maternal blood volume. You're also going to have to get your minerals, your zinc, prevents any kind of deficiency in the fetus and the maternal stores, fetal growth, milk production, iron. We always want to make sure that the woman is getting plenty of iron, whether she needs to supplement it with pills or she just needs to increase it in her diet. One thing that NCLEX loves to ask you is about nutrients, and they'll say, this woman needs more iron, how can she get it? And they'll give you a list of foods. You need to be able to pick out which foods are going to be best to give her the iron that she needs, or XYZ, whatever that might be. Calcium. Calcium helps with nerve cell transmission, muscle contraction, bone building, and blood clotting. Phosphorus, it works alongside the calcium. Calcium metabolism requires a normal amount of phosphorus to build those strong bones. Vitamin requirements, folic acid. Folic acid is a huge one for pregnancy. And the reason that is because it helps aid in the formation of the nervous system. Now, whenever we study in chapter 5 the growth of the fetus and seeing it from conception all the way to the end, you will learn that week 5 is detrimental to fetuses and their growth. And that is when they're growing their brain, their nervous system. And so the folic acid is vital for that. And that's why we encourage all women to be on a prenatal vitamin, whether they're planning a pregnancy or they're just not taking birth control. Everyone needs to be on a prenatal vitamin if you're in that range of able to have children. And it's because a lot of times at 5 weeks, women don't even know that they're pregnant yet. And yet that is when the baby is developing one of the most critical organs in the whole body. Okay, so folic acid, can't say enough about that. We have to make sure that she's getting the right requirement of folic acid, and that's at least 400 micrograms a day. You can get that in a prenatal vitamin. It has plenty. Just make sure that you're taking the prenatal vitamin. Vitamin A, too much can be toxic to the fetus, but too little can stunt the fetus's growth. So again, as long as you're taking a prenatal vitamin, you're probably getting plenty of vitamin A. Vitamin C, it's essential in the formation of collagen, a necessary ingredient for wound healing. Vitamin B6 is necessary for healthy development of the fetus's nerve system. B12 needed to maintain healthy nerve cells and red blood cells and to form DNA. So you can see where all of those things are very important. There are also some special nutritional considerations. If the woman is a vegetarian, that is fine, but we have to make sure that she is getting all of those nutrient requirements that she needs. And often you'll find that they eat way better than you ever thought of, so they're probably getting that just by taking the supplement, a prenatal vitamin, and maybe something else, a little bit of iron on top of that. Lactose intolerant, of course, they need to be getting their calcium from somewhere, so it's teaching them and educating. And your ATI book goes into great detail in chapter 3 about nutrition, so make sure that you read that. Pica is an iron deficiency anemia. Often it's caused by eating strange objects, like you're craving ice and you just can't eat enough ice or dirt, and you're trying to get that iron from somewhere. So we also have to watch out for that. But as long as the client is eating a balanced diet and taking a prenatal vitamin, she should be meeting all of her nutritional needs. Alright, so ATI chapters 2, antepartum nursing care, the prenatal care, and then chapters 3, nutrition. Make sure that you look over those. See you in class.